Good afternoon, ladies and gentlemen. We'll start our session now, the radiology session. I'm very happy to be among you all. I want to thank Dr. Rasha Kamal for giving me this opportunity. I am chairing this session and co-chairing with my colleagues, Dr. Salwa Fatahi and Dr. Haytham, and I wish you a very fruitful session. The first speaker is Dr. Amr Farouk. He's an assistant professor of diagnostic and interventional radiology, NCI, and a radiology consultant at Bahia Foundation. He's going to give us a lecture under the title, A New Era in Breast Biopsy Techniques. Dr. Amr.
Thank you. First, adequate biopsy and excision of lesions identifying imaging techniques has two consequences. First, it makes it possible to remove an adequate volume of tissue, increasing diagnostic certainty and reduce the likelihood of underdiagnosis. Second, it allows complete removal of lesion in selected cases. VAP is shifted from diagnosis to percutaneous treatment to specific type of lesions. So for comparison between the TrueCut biopsy and the vacuum-assisted biopsy, the vacuum-assisted biopsy is mildly invasive in comparison to the less invasive TrueCut biopsy. It provides larger sample volume, decreases the likelihood of underdiagnosis of complex lesion, and rendering the need to surgical biopsy and decrease incidence of malignancy upgrade in comparison to conventional core biopsies. Also, once the needle is inserted into the breast, removal of all sample is a continuous, uninterrupted, combining tissue aspiration and cutting. When we compare the surgical biopsy and the vacuum-assisted biopsy, the surgical biopsy will be more invasive with larger size of scar. However, the drawback of vacuum-assisted biopsy is that the specimen will be fragmented, limiting the evaluation of margin and internal architecture. So we have TrueCut biopsy, the vacuum-assisted biopsy, and the surgical excision biopsy. The VAP doesn't replace the core biopsy in non-complex lesion. It's an alternative to surgery. For the image-guided breast intervention, the gold standard is ultrasound for ultrasound-visible lesions, stereotactic guided biopsy for calcification and lesions not clearly seen by ultrasound. Digital breast tomosynthesis is the same as stereo, but better to be done for cases specifically seen or better seen in tomosynthesis as distortions. For the guidance techniques, we have the 2D and the tomosynthesis stereotactic and the ultrasound. For the cost of the stereotactic guided biopsy, it will be more expensive than ultrasound. It will be less comfortable than ultrasound, with limitation in the location of the lesions in the stereotactic guided biopsy for deep lesions, retroareolar, and next to the pectoral muscle, or when the breast is very thin to be under compression. For ultrasound, there is no limitation regarding the location. For the breast geometry, the stereotactic guided biopsy should be perpendicular to the greater axis of the lesion, while in the ultrasound, it should be parallel to the lesion. For the size, it's easier to control the position of the needle when the lesion is bigger than the biopsy chamber, more than for the stereotactic guided biopsy. Here comes the state-of-art contrast-guided biopsy and MRI-guided biopsy for detected only lesions in MRI and contrast, which are better depicted with contrast. So traditionally, for enhancing lesion appreciated in MRI and contrast, this would have necessitated an MRI-guided breast biopsy. However, contrast-enhanced spectral mammography breast biopsy has been recently introduced into the clinical practice. For the guiding techniques, whether the MRI-guided or the contrast-enhanced mammography guidance, it's much more costly to do the MRI-guided biopsy. It's not widely available. It's much less comfortable to do it than the contrast-guided biopsy. And the recorded percentage rate of failure is 6 to 13%, mostly due to the non-visualization of the target lesion in MRI, while it's 5% in contrast-guided. The median time for the MRI guidance is 35 minutes, with the room occupancy around 60, 70 minutes, while in contrast-guided biopsy, it's 15 minutes, and the room occupancy around 25 minutes only. There is an added advantage for contrast-guided biopsy. It's the ability to correlate these findings on the recombined images with the findings detected on the low energy or the tomosynthesis, and it's performed during performing the contrast-guided biopsy. Also, the breast geometry between the MRI-guided and the contrast-guided biopsy is different. In the MRI-guided, you have the advantage of being cross-sectional images, avoiding superimposition of artifacts. However, in contrast-guided biopsy, we have this limitation of the overlapping images. We had a contrast-guided biopsy in our first series of patients, including 26 patients with breast lesion detected on contrast mammography only. The patient did contrast-guided biopsy using vacuum-assisted biopsy techniques. We had 26 patients, 11 had incidental finding on contrast, 15 detected on sonomammography, but better appreciated and localized in contrast images. Out of the 26 patients, we had 12 cases underwent significant change of therapeutic plan from follow-up to excisional biopsy, or vice versa, from excisional biopsy to follow-up. Contrast-guided breast biopsy was a feasible technique that was easy to implement and perform, and we showed good success and complication rates and less complication rate and shorter procedural time. Here comes our latest, the image-guided breast intervention, the PEM-guided breast biopsy, in which for better detected lesions in PEM and equivocal lesions that are only detected in PEM. For PEM depend on molecular imaging with similar performance to breast MRI and contrast for staging newly diagnosed breast cancer. It's most often used in the care of women with contraindication to MRI, solving problematic cases detected in MRI as heterogeneously enhancing breast parenchyma. When otherwise occult suspicious lesions are identified with PEM, not detected by other modalities, biopsy is required to direct patient care. This is a video showing the procedure of PEM stereo navigator.
Naviscan PEMFlex PET imaging may be used to guide the core biopsy of a breast abnormality. A needle guide is installed between compression paddles of the Naviscan PEMFlex system. Software instructions help position a needle within the guide. Alignment of the needle track relative to the targeted abnormality is confirmed by PEM imaging with a positron emitting rod. Biopsy cores are extracted and a clip is placed at the biopsy site. A post-biopsy mammogram is recommended to document the placement of the clip. A post-biopsy PET scan can help assure the biopsy sampling is adequate, as can PEM imaging of the biopsy specimens. PEMFlex PET imaging can help guide the core biopsy and assess its effectiveness. You now have a way to identify and biopsy suspicious lesions using PET technology.
Located. Local anesthesia is applied superficial and deep. A skin incision is made using a number 11 scalpel. Insert the targeting set firmly through the hole of the cube in the needle guide holder. Remove the obturator from the targeting set. Insert the PEM line source, still in its casing, into the located relative to the targeted abnormality line source casing, and insert the mammatome samples with the 8-gauge mammatome probe. Amount of samples have been obtained. Place a MammoMark II tissue marker at the biopsy site through the probe or through the obturator of the targeting set. A post-biopsy mammogram is recommended. This may be used to confirm radiotracer uptake in the sampled tissue. The sampled tissue will be located. Local anesthesia is applied superficial and deep. A skin incision is made.
So we do the PEM-guided biopsy using MRI needles for vacuum-assisted. However, we had a modification in Bahia using the ultrasound vacuum needles. This is an example for the initial biopsy targeting, followed by the line source alignment showing the appropriate targeting of the mass, and following the post-biopsy craniocaudal PEM images showing alteration of the mass, confirming the specimen PEM showing areas of elevated uptake in the tissue cores consistent with adequate sampling. This is another case of a 45-year-old woman with suspicious breast mass recently identified at mammography and ultrasound. However, the anteriorly related nodule, it was not properly identified in the ultrasound. The patient did the biopsy for the main mass and the nodule adjacent and anterior to it. The patient had both the lesion and the anteriorly related nodule, both biopsied and showing carcinoma. And in the post-biopsy images, this nodule is no longer visible. Thank you.
Thank you.
Thank you, Dr. Amr, for nice presentation. معلش أنا عايزة بس أقول كلمة صغيرة. دكتور عمرو فاروق الحقيقة أنا بعتبره أخ صغير ليا، مثال للراديولوجيست الأمين، الأونست، الهادي، helpful، scientific. الحقيقة يا عمرو أنا بشكرك على كل اللي أنت بتعمله.
شكرا لحضرتك.
أنا فخورة بيك.
شكرا لحضرتك.
Second speaker, Dr. Mohammed Mohsen. Mohammed Mohsen, Assistant Lecturer of Diagnostic and Intervention Radiology and NCI, National Cancer Institute, Cairo University, and Diagnostic and Intervention Radiology Specialist in Bahia Hospital. The topics: contrast mammography, guided vacuum, assisted biopsy of breast lesions. تفضل يا
Thank you. Contrast mammography, guided vacuum assisted biopsy. The first question we ask is why use this technique? Why we use the contrast enhanced spectrum mammography, and why do we use VAP? To answer the question, there's a quick overview. Mammography is the primary diagnostic tool for screening and diagnosis of breast lesions. Its main limitation is the increased breast density. The specificity of mammograms decreases from 86 and 89% in fatty breasts to 62 to 68% in dense breasts. About 43% of women aged between 40 and 74 years have dense breasts. Breast density itself is an independent risk factor of breast cancer. What is the contrast enhanced spectrum mammography? It simply depends on acquiring pre and post contrast standard mammography views, then subtracting the pre-contrast image from the post-contrast image to yield contrast only image, negating the masking effect of dense breasts. Thus, it significantly increases the specificity and sensitivity of mammography lesions detection, especially in dense breasts. Sometimes lesions are only detectable on contrast-enhanced spectrum mammography and/or the MRI, especially in dense breasts. What is the vacuum-assisted biopsy? It is a relatively novel technique for breast tissue sampling, which primarily depends on single wide-pored needle entry, yielding large amounts of representative specimens via continuous sampling aided by continuous vacuum suction. This is the mammography device. As we can see here, this is the screen. It can go all the way to 360, and this is the handle. This is the vac button. This is a video demonstrating how the vacuum-assisted biopsy is done. This is a quick comparison, as mentioned by Dr. Amr. The vacuum-assisted biopsy is mildly invasive, acquires larger sample volume, and decreases the likelihood of underdiagnosis, decreases the incidence of malignancy upgrade, and depends on single needle entry. Therefore, we have a perfect combination where the contrast-enhanced spectral mammography guided biopsy solves the dilemma of sampling of hidden lesions in dense breasts, while the VAP solves the problem of repetitive entries, thus improving the sampling rate and accuracy of contrast-enhanced mammography-guided biopsy. Moreover, it yields significantly larger sample volume than core needle biopsy. What about the indications? It is a relatively novel technique or a new technique used for lesions not identified by other morphological breast imaging techniques. It is used as an alternative to MRI-guided biopsy. It has a lot of advantages, such as high positive predictive value, short time to the procedure, available, less expensive, more acceptable to the patient where the upright position is more comfortable. Some lesions are difficult to be targeted by MRI, such as the posterior lesions. It is useful when MRI is contraindicated in patients with metallic parts. What about the technique? At first, we localize the site by stereotactic technique. We administer the IV iodinated contrast. And here is the very important to avoid compression early on, to avoid interference of blood flow to the breast, to allow adequate enhancement. After 2 minutes of injection, we apply focal compression. This helps in delaying the washout so that the contrast uptake is visible for about 10 minutes, allowing proper targeting. Then we decide the approach. As we can see, this is the vertical approach, while this is the horizontal approach. Then position the patient, target the lesion at the center of the compression paddle, dual energy imagers at 0 degrees, which is the SCOUT, pair dual imaging, then dual imaging at plus or minus 15 degrees. We disinfect the target area and apply local anesthesia. Then we insert the vacuum-assisted biopsy needle to face the target, and then we acquire the plus and minus 15 degrees views to confirm proper positioning. We activate the VAP needle once the correct direction is confirmed. After sampling, we apply a clip marker and apply heavy compression to avoid hematoma formation. Therefore, to sum up, we first do the patient's positioning, avoid compression, IV contrast injection. We wait for 2 minutes, perform compression, then acquisition is done at 0 and plus or minus 15 degrees with lesion localization. We choose the approach, horizontal or vertical, disinfection and anesthesia, insert the VAP, then acquire pre-fire imaging, start sampling, then place the marker. Patient's aftercare is quite important as manual compression is done at the site of sampling rather than the site of needle entry for 10 minutes to decrease the hematoma formation, which is a major complication in VAP. Tight bandage is then applied and checked at least 3 times every 15 minutes. This aims at decreasing the incidence of hematoma, which is higher in VAP than core needle biopsies. Cases, there's a 29-year-old female patient with negative family history presented with left breast 12 o'clock lump. Contrast mammography was done and revealed left breast multi-quadrant enhancing foci as seen here and here. Contrast enhanced mammography guided biopsy was done. There is the targeting the lesion. This is after the biopsy. And the clip insertion. Diagnosis was fibroadenosis with no atypia or malignancy. Case number 2, a 58-year-old lady presented with positive family history, sister, came for annual screening mammogram, which revealed no newly developed lesions. Ultrasound revealed right upper inner area of altered parenchyma proved pathologically to be invasive ductal carcinoma. Contrast-enhanced mammography was done and revealed right upper inner quadrant malignant mass and left central pathological non-mass enhancement. This is the right and this is the left, is the blue arrow. Contrast-enhanced mammography guided VAP biopsy was done. Diagnosis was invasive duct carcinoma grade 2. A 53-year-old lady with right breast invasive ductal carcinoma. Contrast-enhanced mammogram was done and revealed left breast upper outer area of suspicious non-mass enhancement. Contrast-enhanced mammography guided biopsy was done from the lesion as demonstrated. diagnosis was high-grade DCIS. A 37-year-old lady with positive family history, mother, presented with left-sided bleeding per nipple. Ultrasound examination, not shown, revealed diffuse scattered intraductal papillary growths with no suspicious lesions. Contrast-enhanced mammography-guided biopsy was done and revealed papillomatosis was intermediate-grade ductal carcinoma inside. A 27-year-old lady with concurrent right breast cancer presented for contrast-enhanced mammogram, which was done and revealed left breast upper central area of non-mass enhancement. Stereotactic guided biopsy, contrast-enhanced biopsy was done for such lesion as shown. Fibroadenosis with no atypia or malignancy. To conclude the take-home message, such novel procedure provides more optimal management for certain populations of patients, which are patients with dense breasts. It can guide us towards the best management approach early on, which decreases the patient's mortality and morbidity. It is a potential revolutionary game changer. Thank you.
Thank you, Dr. Mohsen. Thank you, Dr. Mohsen. We will postpone the questions till the end of the session. Okay? Now our next speaker will be Dr. Minna Hanafi. Her presentation is about solving the dilemma of indeterminate breast lesions. Dr. Minna is a lecturer of diagnostic, assistant professor of the diagnostic and interventional radiology, faculty of medicine, Cairo University, and radiology, consultant of Bahia Hospital Foundation for early detection and treatment of breast cancer.
First of all, I'd like to thank my professor, Dr. Rasha Kamal, for her continuous support. And I'd like to thank all my professors and my colleagues. Solving the dilemma of indeterminate breast lesions. The spectrum of indeterminate breast lesions include lesions with indeterminate sonomammographic appearance initially, and lesions with benign morphology yet on follow-up show change in size or morphology, and lesions with malignant morphology, yet biopsy results came to be benign. The dilemma whether these lesions are benign or malignant, should we biopsy or follow up? For lesions with indeterminate sonomammographic appearance, this entity include mass lesions with benign morphology, yet have one or more worrisome features or additional signs. Lesions with indeterminate mammographic findings, yet with no suspicious ultrasound findings. Cysts with internal altered content or thick wall cysts, some specific pathologies as intraductal lesions and fat necrosis. We will start with mass lesions with benign morphology yet have one or more worrisome features. We know that benign mass lesions are usually rounded or oval, circumscribed, iso or hypodense. When mass lesions show benign morphology yet one or more of worrisome features as cystic change, irregular outlines, increased vascularity, microcalcification, increase in size, we should biopsy it. Here in some cases, 35-year-old female presented by palpable right breast mass. Her ultrasound revealed bilateral well-circumscribed mass lesions with internal cystic change and increased vascularity. Biopsy was done, revealing complex fibroadenoma. Once the pathology results are complex fibroadenoma, it should be surgically removed, as fibroadenoma comprise epithelial and stromal component. Its pathological subtypes are simple, juvenile, giant, and complex. The epithelial component of fibroadenoma may develop DCIS or invasive carcinoma with a reported incidence of 1 in 1,000. This incidence is higher in complex adenomas. Complex fibroadenoma's pathology usually reflects its ultrasound appearance. It usually shows apocrine metaplasia reflected as cystic spaces in ultrasound, sclerosing adenosis reflected as irregular outlines, being hypervascular reflected in rapidly increase in size, and microcalcifications. So again, complex fibroadenoma should be surgically removed. A 30-year-old female patient presented with palpable mass in right breast. Her ultrasound revealed macrolobulated mass with cystic changes and mild increased vascularity. Biopsy was done revealing complex adenoma, when it's surgically removed, it was complex fibroadenoma with DCIS intermediate grade. Teaching point, any lesion which doesn't fulfill benign criteria should be biopsied and complex fibroadenoma should be surgically removed. 47-year-old female patient presented with palpable mass in right breast. Her mammography revealed microlobulated mass lesion and ultrasound relieved macrolobulated mass lesion with internal septations. Biopsy was recommended and it was complex adenoma with DCIS. A 62-year-old female came for screening. Her mammography was unremarkable, yet ultrasound revealed left breast 9 o'clock peripherally located macrolobulated mass lesion with cystic changes and increased vascularity that appeared in additional mammographic view. Biopsy was done. It was encapsulated papillary carcinoma. 56-year-old female patient presented with palpable mass in her right breast which rapidly increased in size. Her mammography and ultrasound revealed circumscribed mass lesion with increased vascularity. Biopsy was performed and it was cellular fibroepithelial neoplasm. When it's surgically removed, pathological results was benign phylloid tumor. Once the pathology result is cellular fibroepithelial neoplasm, there is higher incidence to be benign phylloid, so it should be surgically removed. Here again, any lesion which rapidly increases and cellular fibroepithelial neoplasm should be biopsied and surgically removed. 37-year-old female patient presented with palpable mass in the left breast. Her mammography and ultrasound revealed circumscribed mass with microcalcification, cystic changes, and mild increased vascularity. True-cut biopsy and post-operative pathology were complex fibroadenoma with stromal patch. 29-year-old female patient presented with palpable mass in the right breast that recently increased in size. Her ultrasound revealed oval circumscribed mass lesion with moderate vascularity. Initial diagnosis was fibroadenoma. However, it was upgraded by senior staff member to be suspicious and recommend to perform mammogram. As she suspected microcalcifications, her mammogram was ACRD breast with right upper outer quadrant circumscribed mass lesion showing suspicious microcalcifications. Contrast mammography revealed moderate background parenchymal enhancement and intense enhancement of the mass lesion. Biopsy and surgical pathology were complex adenoma with intermediate grade DCIS. Teaching point, microcalcifications are not accepted in fibroadenoma, especially in young age. Then, indeterminate mammographic findings with no suspicious ultrasound findings. 65-year-old female patient presented with nipple discharge. Her mammography revealed left breast subtle distortion. Dynamic MRI was requested, revealing left breast upper outer quadrant segmental enhancing foci. Wire localization was done, revealing invasive lobular carcinoma. So, teaching point, indeterminate mammographic findings should be further assessed by contrast enhanced mammography or MRI and histopathology accordingly. 56-year-old female patient came for screening. Her mammography revealed left breast upper outer quadrant focal asymmetry with distortion and contents parenchyma by ultrasound, and right breast retroareolar mass with increased vascularity. MRI was performed, revealing left retroareolar segmental heterogeneous intense non-mass enhancement with right paraareolar over circumscribed homogeneous intense mass enhancement. Biopsy was performed from both lesions. Left breast was invasive lobular carcinoma and right breast was fibroadenoma with invasive duct carcinoma. Then, cyst with internal altered content or thick wall cyst. 39-year-old female patient presented with palpable left breast mass. Her mammography and ultrasound revealed circumscribed deeply seated mass appearing as cyst in ultrasound with altered avascular content. Biopsy was performed and it was high-grade triple-negative breast cancer. Her MRI showed typical triple-negative breast cancer appearance of high T2 signal and REM enhancement on MRI. Some specific pathologies as intraductal lesions, fat necrosis. 51-year-old female with palpable mass in her right breast. Her mammography revealed right breast retroareal indistinct lesion that is adherent to the nipple. Ultrasound revealed vascular intraductal mass lesions, highly vascular. Pathology was intraductal papilloma with no atypia. Then, for lesions with indeterminate morphology not fulfilling benign criteria, corneal biopsy is recommended, and advanced imaging techniques may be needed. And according to results, short-term follow-up or excision will be recommended. For lesions with benign morphology showing change in size or morphology, this entity include lesions that increase in size more than 25% in 6 months, change in shape or margin, change in vascularity, development of additional features. Here, for 35-year-old female presented with mastalgia, her ultrasound revealed right breast circumscribed mass lesion. On follow-up, it showed increase in size. Biopsy was performed and it was fibroadenoma with PASH. 42-year-old female presented with right breast lump. Her mammography and ultrasound revealed right breast circumscribed mass lesion. On follow-up, it increased in size, and biopsy and surgical pathology was benign phyllite. 34-year-old female presented with palpable right breast mass. Her ultrasound revealed multiple rounded circumscribed hypoechoic lesions. Initially, it was diagnosed as fibroadenoma for close follow-up. Upon follow-up, they showed change in size and morphology with development of calcifications confirmed in mammography that appear, multiple indistinct mass lesions with microcalcification, and biopsy revealed invasive duct carcinoma with mucinous differentiation, appearing in MRI as bright T2 and stir signal, REM enhancement, and MRI also showed additional lesions in the outer breast quadrant. So for lesions with benign morphology at showing change in size or morphology, they were initially assigned by RES 2 or 3 upon follow-up when change in size or morphology. Biopsy is recommended and additional imaging modalities may be needed. For lesions with malignant morphology, yet with benign biopsy results, this entity include benign cancer mimics as inflammatory breast lesions, proliferative breast disorders as sclerosing adenosis, radial scar, ADH, benign breast lesion as fat necrosis, fibromatosis, PASH, and non-representative biopsy. 62-year-old female patient presented with palpable right lump. Her mammography revealed right breast global asymmetry with altered parenchyma. Biopsy was ADH. VAB was sclerosing adenosis. On surgical excision, surgical pathology was intermediate grade DCIS. 44-year-old female came for screening. Her mammography revealed, compared to previous studies, left upper outer quadrant developing asymmetry with no suspicious ultrasound findings. Stereotactic biopsy was performed, revealing PASH. Contrast-enhanced mammography showed no enhancing lesions. Here, biopsy results were concordant with the ultrasound and contrast-enhanced mammography findings. Screening mammogram of 60-year-old female. Her mammography showed subtle right breast asymmetries. On contrast-enhanced mammography, multiple enhancing nodules were seen corresponding to these asymmetries. In ultrasound, multiple hypoechoic lesions, some of them are intraductal. Biopsy was performed, and the results were papillary neoplasm with atypia, while localization of the most suspicious one was done, and surgical pathology was invasive duct carcinoma and papillomatosis. 30-year-old female presented by left breast lump. Her ultrasound and mammography showed her ultrasound revealed left breast hypoechoic speculated mass lesions, and mammography confirms the ultrasound findings. Contrast-enhanced mammography revealed left breast speculated irregular mass lesion. Biopsy and surgical pathology were sclerosing adenosis. So for lesions with malignant morphology, yet with benign biopsy results, re-evaluate your finding. You can ask for additional imaging, and if they are concordant, short-term follow-up is recommended, strict short-term follow-up, and accordingly, upgrade or downgrade if discordant, consider rebiopsy and recommendation of surgical excision. And finally, radiologists should be aware of the spectrum of indeterminate lesions of the breast. Knowledge of these lesions will enable breast imaging radiologists to suggest an adequate diagnostic and follow-up algorithm so that these lesions are adequately managed and in the same time avoiding unnecessary invasive procedure in many cases. Thank you.
منا عايزه اسالك سؤال. يعني بعد المحاضره دي كده انت في كل حالات الفايبرو ادينوما ها كده يبقى تخلينا في السيف سايد ونشيل الايه اكسجن. لا ما هو بصي ما فيش يعني دي حاجه. تاني حاجه انت قلتي باتش 4 مرات. يعني ممكن حد ما يبقاش عارف ايه الابريفيشن بتاعها. ايه؟ طيب يعني يا ريت اللي تبقى الحاجات الكومن قوي هي اللي تتعمل لان انا مش متاكده ان كل الناس اللي سامعه عارفه الباتش ليه ايه.
Mena, I liked very much your presentation. Your presentation skills and your English were perfect. I love them very much. I have a question for you. على follow-up of fibroadenoma that didn't increase in size and didn't show any vascularity, how long should you follow it up?
Follow-up by ultrasound for 2 years every 6 months.
Exactly. Actually, it was always 2 years, and now it's upgraded to 3 years. So fibroadenoma, if it looks like a fibroadenoma, even though it didn't increase in size or didn't show extra vascularity, we should follow it up till 3 years.
2 months, 2 or 3, 2 years or 3 years
Yes.
at least.
Yes.
Every 6 months.
Even though if there is no change in anything.
Yes.
Yes, thank you very much. And what do you mean by indeterminate breast lesions? You mean by RAS3?
Virus 3 and or 4A.
And 4A, exactly. Thank you very much.
Thanks, Dr. Minna. And now the next topic about artificial intelligence in papillary present lesions, present by Dr. Yasmin Nada, breast imaging radiologist at Bahia Center for early detection and treatment.
Good evening, everyone. Today we'll talk about AI in papillary lesions. What is AI? AI describes the ability of machines to mimic human cognitive functions. أوطي ولا عالي؟ عالي, okay. Okay, AI describes the ability of machines to mimic human cognitive functions like learning and problem solving. The development and implementation of AI and machine learning for mammography have been ongoing for several decades. AI is a software that aids mammogram reading by providing location information of the detected lesions on mammogram. AI could detect normal, moderate risk, and suspicious mammogram, which may reduce the radiologist's workload. AI performed consistently across breast densities. AI is mainly used in screening programs to reduce radiologist workload. So, it interprets the data in 2 ways, qualitatively through showing the magnitude of abnormality as color hue, and quantitatively like with numerical estimate of the degree of confidence for suspicious of malignancy that lies within 10 to 100%. AI is highly sensitive to microcalcification and show high specificity to malignant shapes and distribution. It also shows high sensitivity to irregular and speculate masses as well for architecture distortion. The cancer detection performance of the AI system was reduced with increasing breast densities, which was expected due to masking by fibroglandular tissue. Also, it's reduced in circumscribed masses, even in non-dense breasts, also in large circumscribed lesions occupying the whole breast and asymmetries with no calcification. So we have a question here. So can the AI be helpful in detecting all lesions? What about masses of papillary nature? So to see that, we first need to know different types of papillary lesions and their corresponding mammography findings. So what is papillary lesions? They are heterogeneous group of diseases characterized by the presence of epithelial proliferation supported by fibrovascular cores, attachment to the wall of ducts, extension into the duct lumen, and the fibrovascular core is the hallmark of the papillary lesions. They are rare tumors. They account for less than 3% of all breast tumors, less than 10% of all benign tumor lesions, and less than 2% of all malignant lesions. And they are of good prognosis, usually manifested with palpable breast lump, with nipple discharge, but also can be asymptomatic. They are classified into benign, like intraductal papilloma, intraductal papillomatosis, atypical, like papilloma with atibia and papilloma with DCIS, malignant non-invasive, like papillary DCIS, encapsulated solid papillary carcinoma, or invasive, like encapsulated and solid papillary carcinoma with invasion and invasive papillary carcinoma. So let's start first with the benign. Intraductal papilloma are central retroareolar lesions with round or oval shape and circumscribed margin associated to dilated ducts. Intraductal papillomatosis are peripherally located multiple lesions, rounded or oval in shape, circumscribed margin, and associated with dilated ducts. Papilloma with atibia and papilloma with DCIS are similar to benign papillomas as well-circumscribed masses with or without group of microcalcification. A papillary DCIS as a variant from the DCIS, they are peripherally located, multicentric, may present as polymorphic microcalcification in only a portion of the lesion, so it may extend beyond the zone of mammographically detected suspicious microcalcification. Encapsulated papillary carcinoma, they are solitarily located within centrally sticky dilated duct, typically well-circumscribed, complex cystic mass seen by ultrasound. Solid papillary carcinoma, they are 95% unilateral, typically solid, central nodules, often multinodular, involving the peripheral areas. Invasive papillary carcinoma are nodular densities, which may be multiple and are frequently lobulated. Calcification are not usually evident despite the commonly associated DCIS. Pure encapsulated and solid papillary carcinoma are considered in situ. The invasive type are usually associated with DCIS or invasive cancer around the periphery of the tumor. They are rarely show speculation. The presence of focal irregularity or speculation should raise the suspicion of invasive component or associated invasive carcinoma. So we're having a challenge here, small challenge, but before doing the challenge, we need to know first that the radiologist evaluates the mammogram with the reference to more clinical information and other diagnostic tools like ultrasound, where the AI reads only the image based on its own algorithm. So I need some interpretation here. I will show you some cases, and I need to point out the lesion and mention whether it is benign or suspicious. The first case, where is the lesion? Right or left? Left. Okay, let's see it in close. It's a well-circumscribed, centrally located lesion, seen retroareolar with associated anterior tubular density. It seems to be dilated duct. Let's see the AI. What's the score? What do you think? Is it benign or suspicious? Okay, let's see the AI. No score. The AI didn't give it any score. So the result came out to be papillary DCIS because it's a well-circumscribed lesion. Okay, the second case. Where is the lesion? Right or left? Right. So see it enclosed. It's a retroareolar, centrally located, ill-defined lesion of high density. Okay. So let's see the AI. I think it's very suspicious, very obvious. Okay, giving it a very high score, but there is another lesion in the other breast. Let's see it enclosed. It's already missed, right? See it enclosed. It's a calcification of linear distribution, amorphous in shape, and it came out to be left papillary DCIS. So it's very clever in calcification. Okay, the third case, where is the lesion? Right, bilateral. Actually, I'm pointing to the right lesion because it's more ill-defined. right, with irregular outline. And let's see the AI. What do you think, benign or suspicious? Suspicious, right? Okay, let's see the AI. Oh, very high score, right? So let's see the pathology, solid papillary carcinoma in situ. Okay. Okay, the fourth case, where is the lesion? I think it's very obvious, right? Both breasts. Let's start with the left one. The left one showed an ill-defined retroareolar lesion with another deeply seated calcification seen at the most posterior end, okay, at the zone C, and see it enclosed, okay? Okay, and see the other lesion. It's a large, well-circumscribed lesion occupying the whole breast tissue. And let's see, I think it is suspicious or benign. Suspicious, right? Let's see the AI. Uh-oh, no mark on the AI. So let's see the pathology. It's right encapsulated papillary carcinoma with no invasion, and the left encapsulated papillary carcinoma with intermediate grade DCIS of papillary pattern. I said before that the AI don't detect large breast lesions that occupy the whole breast size. Okay, the fifth case, where is the lesion? Both, right? So I'm concerned with the left breast lesion. What the breast lesion said, it's a deeply seated, centrally located, well-circumscribed lesion. Let's see it enclosed, partially circumscribed, partially irregular outline. What do you think? The AI will show it or not? Is it benign or suspicious for you? Suspicious, right? Let's see the AI. Oh, no marking on the AI, right? So the pathology came out to be encapsulated papillary carcinoma with no invasion, okay? The sixth case, let's see the sixth case. Where is the lesion? This one is difficult. Where is the lesion? Right or left? Right? Both? Right, right? Okay, let's see in close. It's a faint asymmetry seen at the upper outer quadrant associated with microcalcification, as you see. So what do you think the AI showed? Is it benign or malignant or suspicious? Suspicious, right? Let's see the AI. Oh, very high marking because of the calcification. In spite also it is very dense breast. It's saying that it shows reduced sensitivity to the dense breast. So what is the calcification? So what is the pathology result came out to be? Intraductal papillomas. Okay. Okay, the final case. Where is the lesion? This one was my case. Right or left? Left, right? Left? Okay. If there is an asymmetry seen here, have you seen it? The asymmetry? Okay, let's see the AI. Is it suspicious or benign? Suspicious, right? For you, is it suspicious? Okay, let's see the AI. No marking. Okay, and the pathology, what it came out to be? علق. Okay, papilloma with DCIS. Okay? So, in summary, to sum up the full lecture, the classification and morphological imaging characteristics of papillary lesions are still challenging for both radiologists and AI. So, imaging can help to differentiate the forms of papillary lesion, but surgical specimens are required to definitive diagnosis in the majority of cases. The use of AI as a complementary method to mammography may increase the reader's confidence in predicting the probability of malignancy of this type of breast cancer, even in the presence of benign imaging criteria by mammography. Thank you.
Thank you very much, Yasmin, for your very good presentation. And we can have a few questions to Yasmin from the floor. Any questions to Yasmin from the floor? Okay, Dr. Salwa.
I want to ask about the sensitivity and the specificity of AI. You don't mention about the sensitivity.
I didn't mention about the sensitivity because it's ongoing study still. We didn't do any research except in encapsulated lesions. It shows some actually high sensitivity and specificity to the encapsulated lesions. It's about a paper I have done it, a poster I have done it in the USOBI already. But still the other researches we didn't, we are still ongoing for the researches on the other lesions.
Do you calculate the accuracy of AI?
We can, oh, yeah, we can, but still, we still ongoing researches on this AI study.
الحقيقة with talking about AI, we should not forget
Dr. Saha Mansour, of course, yes.
who was the first one to start
course.
working on the AI and giving very good results.
Yeah.
And I'm very happy with the results to Yasmin, actually.
Thank you, Dr.
Thank you
Dore.
very
Thank you
much.
so much. Thank you.
Okay, our next speaker. Our next speaker is Dr. Dalia Al-Mesidi, who is an assistant professor of diagnostic and interventional radiology in Qasr Al-Aini Hospital. She will be presenting a lecture under the title, The Dilemma of Breast Calcifications. And this is one of the very most important points in breast imaging, actually.
Bismillahirrahmanirrahim. Good afternoon, dear professors and colleagues. Today I'm going to discuss the dilemma of diagnosing breast calcification. We need to arrange our random knowledge into experience and wisdom so that we can turn it into the best management recommendation for the patient. First of all, breast calcification. First of all, breast calcification may be the only sign of cancer. At histologic examination, it accounts up to 50 to 80% of cancers. However, a smaller percentage is shown on mammography. To increase its detection, we need to use magnification, either through air gap techniques or electronic magnification. And we also need to compare both views. So if a cluster is seen only one view and is not seen on the other, it represents overlapping tissues. And if it's seen in both views, it's a true cluster and not a fake one. Calcification can result from both malignant or benign conditions. Malignant conditions usually start in the terminal duct lobular unit, and benign conditions can be seen in the interlobular stroma, blood vessels, fat, skin, muscle, or the nipple. So when a radiologist is faced with breast calcification, he has to decide, is it the more happy scenario of benign calcification, or is the less happy and the less common malignant calcification? Evaluating calcification, we need to check on their morphology and size, their distribution, as well as their change over time. Referring to the ACR by RADS Atlas, calcifications can be typically benign, those of suspicious morphology, and we need to assess their distribution. We'll start with the more common scenario of benign calcification. The first type is skin calcification, which are usually tiny and often occur in areas of skin folds where skin touches other skin, such as the intramammary folds and axillae. They are classically egg-shaped and may contain a lucent center. Vascular calcification are associated with atherosclerosis of blood vessels. They have a parallel configuration and resemble tram tracks. Large rod-like calcification are usually associated with benign conditions such as plasma cell mastitis and duct ectasia. They are formed within the ectatic ducts and so follow a ductal distribution and grow towards the nipple. They're commonly bilateral, they're large and rod-shaped and may contain lucent centers. Another type is the round or punctate calcification, especially if they contain a lucent center. The rim or eggshell calcification commonly accompany small oil cysts. Another type is the dystrophic calcification, which usually follows irradiation or trauma, and a more severe type of dystrophic calcification can accompany fat necrosis. The milk of calcium is another type of benign calcification which precipitates in one view and is more dispersed on the other. Popcorn calcification defines involuted adenomas, but it's of note that early on, calcification in an adenoma can be very fine. Regarding the distribution of benign calcification, it has not to favor a ductal or a group distribution. It can be either diffuse or regional. It suggests innumerable scattered and occasionally clustered calcifications widely dispersed over both breasts. It reflects its causing processes, which are again widely spread within both breasts. commonly due to fibrocystic changes. Diffuse or extensive calcifications can rarely represent breast cancer. Benign calcifications do not change over time. However, we can only account for stability over time as a sign of benignity only if the calcification is of benign morphology. If we detect a definitely benign calcification, the patient is given the BI-RADS category of 2, and she is dismissed for her routine annual screening. We are then going to discuss the less happy scenario of suspicious calcification. Referring again to the ACR by LADS Atlas, suspicious calcification can be divided into those with moderate suspicion, such as amorphous or coarse heterogeneous calcification, or those with higher suspicion, such as fine pleomorphic or fine linear or fine linear branching calcification. Amorphous calcification are usually so small and hazy that they do not have a clearly defined shape or form. They may be of benign etiology, which is commonly fibrocystic changes of the breast, especially when they are more diffuse and bilateral. However, if they're unilateral or grouped, they are more suspicious and commonly accompany a typical ductal hyperplasia, a typical lobular hyperplasia, ductal carcinoma in situ, or invasive ductal carcinoma, especially if they're associated with an accompanying mass. However, this overlap between benign and malignant appearing calcification may result in false positive biopsies, reaching up to 75% of benign biopsies resulting from procedures prompted by calcification. Another type of calcification of moderate suspicion are those of the coarse heterogeneous calcification. These are very tiny and irregularly shaped calcific particles that look like broken glass shards. They form inside the pockets of necrotic tumors, such as micropapillary or cribriform forms of ductal carcinoma in situ. The individual calcifications are roughly round in shape, but have irregular borders and are faint and may vary in size. Again, coarse heterogeneous calcification can be due to a benign cause if they are bilateral and scattered, commonly fibrocystic changes. Again, if they are grouped or unilateral or having ductal or segmental distribution, they are more suspicious. These are examples of coarse heterogeneous calcification. Calcification of higher suspicion are those having fine linear or fine linear branching shape. They develop in ductal carcinoma in situ or invasive cancers which grow in breast ducts and have the classic appearances of X, Y, or Z-shaped letters, or the more classic described Chinese letter appearance. These are examples of the fine pleomorphic calcification. Another type is the fine linear or fine linear branching calcification, which cast the lumen of ducts, and these are classified as BI-RADS 5 calcification. Suspicious calcification have to have a distribution being grouped or linear or segmental distribution following ductal branching. It's of note that because calcification can be the only sign of malignancy, it's important to analyze all the individual calcifications in the cluster. And a calcification cluster should not be dismissed simply because it contains some benign appearing calcification. The decision of biopsy should be based on the worst looking calcification on the group. So if suspicious calcification is discovered, the patient is given a BI-RADS category 4 or 5 according to the individual case, and calcifications have to be evaluated pathologically. The report for calcification should include the size of the cluster, its location, whether right or left, quadrant location, clock position, distance from the nipple, the shape of the cluster, its overall characteristics, especially of the worst looking individual calcifications, its associated findings, change comparing to previous imaging and its BI-RADS score, and finally the management recommendations. Associated findings could include a mass, an architectural distortion, axillary lymphadenopathy, skin retraction or thickening, nipple retraction, or trabecular thickening and breast edema. Finally, my take-home message is, even if we know all the theories and master all the techniques, but as we touch another human soul, we need to be another one. Thank you.
Thank you very much, دكتورة داليا.
Thank you very much, Dalia, for your presentation. What I liked about Dalia is that she's putting a reference to her slides. And this is very important. الأمانة العلمية دي مهمة قوي. أي حاجة تاخدها من حد تاني لازم تحط الريفرنس. And this is what I liked about your presentation. Besides, of course, the rest of your slides. Thank you very much.
شكله ثانية بس. Next speaker, Dr. محمود مخيمر, lecturer of radiology, Cairo University. مش أنت معانا في القصر العيني؟ Faculty of Medicine, Cairo University, and radiology consultant in Bahia Hospital. The topics is PET mammography from indications to interpretation.
بسم الله الرحمن الرحيم. Positron emission mammography from indication to interpretation. تمام. BIM involved the use of FDG for detection of glucose metabolism by breast lesion, so it is considered a functional imaging modality. Mechanism of action: FDG is taken up onto the carcel cells via the glucose transporter 1. Then it becomes phosphorylated and trapped inside the cells as it can be transported back, leading to its accumulation inside the cells. BIM devices, there are two main types. The first one, the patient are seated upright position with the breast gently stabilized between the two compression pedals, with similar to mammography. The other device, the patient are scanned in prone position. The patient lies prone with the device has two or more complete moving detectors, and the breast hangs pendulously within the ring without any compression. BIM scans were done using Naviscan BIM Flex Solo 2. The patient is fasting for 4 to 6 hours, then blood glucose was checked and should be less than 150 milligram per deciliter. Then the FDG is injected with average dose of 5 to 10 millicurie, and the scan is started after 90 to 120 minutes. The patient are seated upright with the breast gently stabilized between the pedals, and images are acquired in craniocaudal and mediolateral obliques, similar to mammography, in addition to the axillary views. 12 images for each breast for each fuse are acquired, with the total scan time, the scan time 10 minutes for each breast, and total scan time of 40 minutes. The scan images can be viewed in different color scales. Indication for BIM: indeterminate breast lesions as a complementary tool to mammography and ultrasound, indeterminate breast lesion in patient with dense breast, and contraindication to MRI or claustrophobia, patient with renal insufficiency, initial staging evaluation of the breast cancer, either multifocal or multicentric, but not for the axillary lymph node staging, differentiating recurrent carcinoma from scar tissue, and monitor response to neoadjuvant chemotherapy. Advantage: BIM has higher spatial resolution than PET. It can detect small cancer up to 2 millimeter and lower grade lesions. It is an alternative to MRI in newly diagnosed patient when MRI is contraindicated, as patient with cardiac pacemaker or advanced renal disease. BIM images can be correlated with those of mammography in case of equivocal increased FDG uptake on areas of normal fibroglandular density. It also can predict tumor aggressiveness. This advantage can be grouped into false positive result, either due to infection, inflammatory process, or recent post-operative changes, benign lesions as fibrocystic disease and fibroadenoma, especially during the rapid growth phase and increased breast density. False negative result can be due to lesion outside field of view, lesion in the posterior aspect of the breast, lesion close to the chest wall, and larger breast. Lobular carcinoma have decreased vascularity and metabolic activity. Radiation exposure, BIM has 15-fold higher risk of cancer induction compared to a single digital mammogram. The whole body organs are exposed to radiation, unlike mammography. For this reason, it is unlikely to be used in screening. Interpretation of BIM includes qualitative approach similar to MRI and other quantitative approach similar to BIT. In BIM, we calculate the BIM uptake value BUV and lesion to background ratio LTB. Qualitative assessment, we assess for the size, multiplicity, and extension and the associated finding. Multiplicity and extension, this is a 41-year-old female patient with renal failure complaining of right breast lump. Mammography revealed right upper quadrant suspicious mass, while BIM revealed right upper quadrant multicentric FDG avid mass lesion. Postoperative pathology result revealed right breast multicentric invasive duct carcinoma grade 1. Lesion taking or showing radiotracer uptake can be focused. It is tiny uptake less than 5 mm, too small to be characterized morphologically, or mass, three-dimensional lesion with a specific shape and internal FG uptake, or non-mass with a tracer uptake in an area different from normal surrounding parenchyma, but not foci or masses. This is case 1 showing a single FDG avid single malignant lesion, and this left breast diffuse regional non-mass lesion, and this tiny left breast FDG avid focal lesion. Degree of radiotracer uptake can be no radiotracer uptake at all. This goes with benign lesions, or mild radiotracer uptake can be benign or some malignant lesion, and intense radiotracer uptake, this with the malignant lesion and few benign lesion. And in these two groups, we need further differentiation using quantitative assessment. Associated finding also then can show diffuse skin increased uptake, denoting skin infiltration, or increased naval activity denoting infiltration. For quantitative assessment, two ROI are placed. The first one is placed over the lesion to calculate the BUV max. The second ROI is used to calculate the background BUV mean. It should be placed over area, normal breast area representative of mixed fibroglandular and fatty tissue. The LTB ratio is calculated as the ratio of BUV max of the lesion to the background BUV mean. The intensity of radiotracer uptake correlates with increasing tumor grade, increases in triple-negative cancer, decreases in lobular carcinoma and SIS. Also, uptake correlates with the risk of nodal metastasis and response to neoadjuvant chemotherapy. In a study performed at Bahia Hospital, a calculated threshold cutoff value of BUV max more than 1.95 and cutoff value of LTB more than 3.1 were considered predictive of malignancy. Also, false negative cases were low-grade DSIS and invasive lobular carcinoma, while false positive cases were inflammatory breast lesion and those benign lesions like fibroadenoma and papilloma. This is a 48-year-old female patient complaining of left breast lump. Mammography revealed left breast isodense upper outer quadrant lesion showing suspicious microcalcification. Biopsy was done and revealed left breast invasive duct carcinoma grade 3. Due to the dense breast, contrast mammography was advised and revealed left breast heterogeneously enhancing upper outer quadrant mass lesion with surrounding anterior non-mass enhancement reaching the nipple. Also, upper outer quadrant rim enhancing complicated cyst. It shows in the right breast, right upper inner quadrant non-mass enhancement. BIM was ordered and revealed left breast upper outer quadrant single FDG avid malignant mass lesion with the right For right breast, there is right upper inner quadrant, faint, low grade, FDG uptake, non-mass lesion. The left breast lesion reads POV max 10.9 with LTB 11.15, while the right non-mass shows POV max 1.6, the LTB 1.5. Pathology from the right breast using VAP technique was done and showed right fibroadenosis and fibrocystic disease with no malignancy. Case to a 42 years old female patient complaining of right breast lump. Mammography revealed shrunken right breast showing diffuse parenchymal infiltration with asymmetry with diffuse skin thickening. Ultrasound also revealed diffuse infiltrating hypoechoic lesion. A biopsy was done and revealed right breast invasive lobular carcinoma grade 3. MRI was advised and revealed shrunken right breast showing diffuse globular non-mass enhancement occupying the whole right breast, and also left breast retroalular rim enhancing lesion with type 1 curve, and left breast 2-3 o'clock in the area of altered parenchyma with no corresponding enhancement in the MRI. BIM was advised and revealed shrunken right breast showing being occupied by multiple non-circumscribed FDG avid lesion reading BOV max 3.4 and LTB 4.88. Left breast upper outer quadrant small FDG avid nodules reading BOV max 2 and LTB 2.4. Biopsy was done from the left breast upper outer quadrant nodules and revealed invasive lobular carcinoma grade 2. A 61-year-old female patient with renal failure complaining of left breast lump. Mammography revealed left breast upper outer quadrant regular speculated lesion and right breast lower inner quadrant deeply seated another speculated lesion. Biopsy revealed left breast invasive duct carcinoma grade 1 and right breast invasive duct carcinoma grade 2. PIM was advised and revealed right breast deeply seated, partially out of field of view, FDG avid malignant lesion reading BOV max 1.9 and LTB 3.24. Also, left breast upper outer quadrant regular FDG avid lesion reading BOV max 4.6 and LTB with associated small FDG avid nodules and non-mass FDG uptake of intervening parenchyma denoting infiltration. Pathology revealed right breast single malignant lesion and left breast multicentric malignant bruise. A 49-year-old patient complaining of left breast lump. It shows left axillary region irregular dense lesion and right breast isodense lesion with calcification denoting adenoma. A biopsy from the left breast axillary region mass lesion was advised after the BIM. The BIM also revealed this patient, we proceed for the BIM, not for contrast, as the patient gave previous severe reaction to contrast medium. The BIM revealed left breast axillary mass lesion, FDG avid uptake, reading BOV max 3.9 and LTB 5.3. No other breast lesions were noted. Biopsy was done and revealed left breast invasive duct carcinoma grade 2. The MDT decision was neoadjuvant chemotherapy followed by conservative breast surgery. BIM was done after the completion of the chemotherapy and relief non-visualization of the previously noted left breast axillary region malignant mass. Conservative breast surgery result revealed no residual of viable tumor tissue. Take-home message, BIM can detect lesion very accurately, can detect the lesion size very accurately. With result close to the post-operative pathology result, BIM can play a substantial role in assessing the extent of the disease in newly diagnosed breast cancer patients, especially in women seeking breast conservative surgery. BIM can be used to predict tumor aggressiveness. Also, BIM is a complementary examination to mammography and ultrasound. BIM shouldn't be considered a standalone examination. BIM has a limited role in assessing the axillary lymph node, and failure of visualization of the lymph node doesn't mean they are free of metastatic disease. Thank you.
Thank you, Dr. Muhammad. Dr. Muhammad, thank you. Mahmoud, thank you. I want to ask you a single question. يعني if you have both contrast mammography and PET and PIM, what are you going to do for the patient?
لو البيشنت
يعني what are you going to do for the patient? They give the same result except طبعا الSUV. لكن أنا بسأل هل أنت عندك الاثنين تكنيك؟ هتعمل contrast mammography ولا هتعمل PIM؟
لو العيانه ما عندهاش كونتر انديكيشن
والبوست وايز كمان حط.
لو العيانه ما عندهاش اي كونتر انديكيشن تو كونتراست هجو وذ كونتراست.
يعني ويل ستارت وذ ذا كونتراست. ما انا ما بتكلمش على ان في رينال فيلير ولا اي حاجه. انا بتكلم ان هي بيشنت عاديه انت عايز تعمل كونتراست ستادي وات ايفر يعني.
بالظبط. هو البيم ممكن يكون بعد الكونتراست، لان الكونتراست ممكن يكون انهانسنج نوديولز. ده انا مش عارف ديت هتبقى مالتي سنتريك هعمل لها MRM ولا ديت جاست ادينوتيك نوديولز فور كونسرفتيف. البيم في نفس الحاله اللي انا وريتها بينت ان ديت جاست ادينوتيك نوديولز.
يعني انت تو اكسكلود مثلا مالتي سنتريست كونفيرم او اكسكلود مالتي سنتريست. يعني اي حاله لقينا فيها نوديول جنب الماس مثلا بتاعتها واخده فيها كونتراست اتس بريفيرد ان انت تعمل لها.
ده هيأكد ان دي بناين حاجه بناين ولا ديت مالجنانت فوساي برضه.
يعني وفي الحاله دي مش هتحتاج ان انت تعمل بايوبسي؟
لا، في حالات ان هو خلاص مش بيبين اي ابتيك خالص، فديت لا هقول ان هي with benign lesion benign nodules مش malignant.
ثانك يو. الكوست بقى يعني الكوست وايز بقى.
لا هو اغلى من الMRI طبعا. هو اغلى من الMRI يعني.
اغلى من الMRI كمان. والدوز اوف راديشن
هو ديت من الدروباكس بتاعته ان هو عشان كده مش هنقدر نستخدمه في سكريننج الراديشن دوز، عشان هي على كل الاورجان باديز مش على البريست بس في
يعني الفحص بيتعمل بحوالي قد ايه بقى يا دكتور؟ فحص في حدود قد ايه؟
لا مش متاكد من السعر ده.
مش متاكد من السعر. طب انا عايزه اقول لك بعد البيم بنحتاج نعمل بيت ولا لا؟ بيت سكان.
لا على عشان البريست
عشان البادي كله.
لا عشان البادي البادي انا ممكن اعمل السي تي تشيست قبل البلفس الاول.
لا بس انت بتبقى عايز تشوف البيت فروم هيد تو تو، يعني بعد ما تعمل البيم هتحتاج بيت.
ما ممكن العكس، لو في بيت بنعمل بيت وبيم في نفس السيشن، تعمل البيت الاول وبعديها
نجيب جهازين يعني بيت وبيم.
بيت
ده خرب.
بس ممكن الاثنين يتعاملوا مع بعض.
يعني
بحقنه واحده
ممكن يتعامل في نفس البعض. بحقنه واحده بالظبط.
طب شكرا يا دكتور.
بس عايزين الحقنه في البيم اقل من البيت، لان
هو يعمل البيت نفس الدوز 5/10. طب ثانك يو. Next speaker will be Dr. أحمد رزيقة. Ahmed Ruzeka is a diagnostic and interventional radiology specialist at Bahia Foundation, assistant lecturer at National Cancer Institute, and he's one of our important students. And his presentation is about the role of second look ultrasound after dynamic MRI breast.
حاضر إن شاء الله. حاضر إن شاء الله. Okay, my presentation is about the role of second look ultrasound after dynamic MRI breast. A real quick introduction. Dynamic MRI breast is usually called the problem-solving tool. Hello. Due to its cross-sectional capabilities, as well as its ability to characterize soft tissue masses, because of the multiple sequences and the signal and the kinetics that are taken. Dynamic MRI breast is highly sensitive to detect breast cancer, and it's capable of detecting minute lesions that were originally missed on the initial memo or ultrasound. However, the primary limitation in this modality is that it has a lot of false positives. Because it's not specific, like some of the malignant features can be seen also in non-malignant lesions. This is where second look ultrasound plays an important and vital role. With the anatomical landmarks that were supplied by the MRI study, ultrasound can further characterize the lesions that were detected on MRI, as well as obviously facilitate biopsy. As we all know, biopsy guided by ultrasound is much easier for the doctor, for the patient, and obviously more cost efficient. Due to its importance, multiple papers were published about this very topic, and it's common practice in Bahia, and it's usually arranged, most probably it's arranged on the same day as the MRI study to not further delay the patient. And the role of the ultrasound is to characterize the lesions, either to downgrade them or upgrade it to biopsy. We're going to talk about some cases that were taken in Bahia, or done in Bahia. This case presented with an enlarged axillary lymph node. Her initial sonomography was normal apart from the enlarged axillary lymph nodes. Biopsy were taken from the axillary lymph nodes and turned out to be metastatic adenocarcinoma of breast origin. Therefore, we proceeded for MRI breast. We can see T1 and T2 images, low signal, irregular, ill-defined, and having restriction on diffusion. The dynamic MRI breast showed enhancement and showed a type 2 curve. This obviously called for a second look ultrasound because it was initially missed, and the lesion looked suspicious. Obviously, it's irregular, ill-defined margins, so we called for biopsy, and this was one of the recent cases, so we still don't know the result of it. So real quick recap about this case. The MRI detected a breast nodule that was not seen on the initial sonomography. Second look ultrasound confirmed it being suspicious, and a biopsy was taken. So in this case, the second look ultrasound upgraded the lesion, making it also feasible for biopsy. Case number 2, this case presented with a lump in the upper outer quadrant of the left breast, and she had a history, she gave us history that she put implants 15 years ago in her breasts. We proceeded for an ultrasound as her initial imaging because she was uncomfortable with the mammography, and it was pathologically proven to be invasive duct carcinoma. We performed an MRI to further evaluate the patient because of her implants. Obviously, this is the original lesion that was seen, that she was complaining, that was an invasive duct carcinoma, and it revealed also another lesion in the left breast that was obviously enhancing and looked suspicious. So second look ultrasound was also requested. Second look ultrasound showed an irregular lesion with angular margins and vascularity on Doppler application. A recap for this case, the MRI detected another left breast nodule that was not seen in the initial sonomography, or the original sonar that she did. Second look ultrasound confirmed it being suspicious. It was taken biopsy and turned out to be invasive duct carcinoma. In this case, we proved that this case had multicenteric disease and therefore changed the management of this case. So in this case also, the second look ultrasound upgraded it, and also we took a biopsy. This case presented to us already pathologically proven in the left breast to be invasive duct carcinoma. As we can see, the malignant looking mass in the upper outer quadrant in the left breast. Ultrasound obviously shows a malignant looking mass with vascularity. MRI was requested to rule out bilaterality and multicentricity. And this is the original mass that she presented with. And the other side showed non-mass clumped nodular enhancement in the right breast, Second look ultrasound was requested and showed multiple upper outer quadrant areas of parenchymal distortion mounting to mass formation. Recap for this case, the MRI detected a left breast non-mass enhancement Cyclic ultrasound confirmed it being suspicious, and the biopsy turned out to be invasive lobular carcinoma. In this case, the ultrasound, because of the ultrasound that upgraded it, the patient became bilateral breast cancer, and therefore obviously changed its management. This patient presented for screening. She wasn't complaining of anything. Initial sonography showed a left breast area of architectural distortion and overlying suspicious microcalcifications. Pathologically proved to be invasive duct carcinoma in the upper outer quadrant. This is the ultrasound. MRI was requested also to rule out bilaterality and multicentricity. It showed another deeply seated lesion around 8 o'clock, and cyclic ultrasound showed a small nodule, and our ultrasound confirmed that it's a small adenotic nodule. So recap, it detected a left breast nodule. Cyclic ultrasound confirmed it being adenotic nodule, and in the surgical pathology, it proved that there was no other lesion other than the original lesion in the left breast. In this case, the cyclic ultrasound downgraded the MRI finding, and we didn't proceed for a biopsy. This case presents to us already also pathologically proven to be right breast invasive lobular carcinoma, as we can see the mass. MRI was originally requested to assess the contralateral side. It revealed subtle left lower outer quadrant area of non-mass enhancement. Cyclic ultrasound showed some small scattered cysts in the anatomical area that was suspicious on MRI. Recap of this case, the MRI detected a left breast non-mass enhancement. Cyclic ultrasound confirmed it being fibrocystic changes, and we sometimes like to being safe than sorry, so we took a biopsy and turned out to be fibrocystic changes. This also proved to be single-sided right breast cancer, and again, cyclic ultrasound downgraded the original finding that was an MRI that was pathological. Case number 6, this case presented with us with a mammography done outside Bahia, showed locally advanced left breast cancer. MRI was requested to originally assess the extent of the left breast cancer. As we can see, the mass on the left side is occupying the whole breast, pathologically proven to be invasive micropillary carcinoma. Incidentally, right breast multiple enhancing foci were detected, showing curve 2 and 3. Cyclic ultrasound showed multiple small benign-looking mass lesions or nodules. Summary of this case, the MRI detected right breast enhancing foci apart from the original left side locally advanced breast cancer. The cyclic ultrasound confirmed it being of benign nature. And again, safe than sorry, we took a biopsy and proved to be adenotic nodules. In this case also, the cyclic ultrasound downgraded it. So when we did the ultrasound, we said that it's likely benign. So when we took the biopsy, that was guided by the curves in the MRI. It helped the pathologist say that, okay, it's an adenotic nodule because we saw an ultrasound as an adenotic nodule. Okay, this case presented with us with a right breast lump. As you can see, it looks malignant on sonography, on ultrasound also. And this was biopsied and invasive tubular carcinoma. Patient did MRI to exclude bilaterality and multicentricity. Pathologically proven right breast upper outer quadrant mass was detected. As we can see, heterogeneous enhancement, as well as multiple left upper outer quadrant enhancing lesion taking a linear distribution. Obviously, this was very suspicious on MRI. So we did cyclic ultrasound to confirm this finding because it was not originally seen on the initial sonography. It showed 2 o'clock altered parenchyma with small suspicious nodules. Again, a recap and the final decision. This case detected left breast enhancing lesions, linear distribution. Cyclic ultrasound confirmed it being suspicious. Biopsy turned out to be fibroadenoma with focal ADH. Yet, due to the suspicious criteria that was on MRI and confirmed on ultrasound, the management of this case changed. In the MDT, they decided that they're going to wire localize the area that was suspicious. It was ultrasound guided, and the pathology turned out to be DCIS. Again, the cyclic ultrasound confirmed it being suspicious. Yet, like I said, because ultrasound and the MRI both agreed on it being suspicious, it changed the management of the case. In conclusion, MRI has multiple applications in detecting and helping in staging breast cancer. It's sensitive yet not specific. Cyclic ultrasound can potentially downgrade incidental suspicious lesions detected at MRI. This may reduce the number of unnecessarily performed biopsies, and this whole entire process simplifies and speeds up the patient management, which is our main objective in any cancer patient. Thank you.
Thank you, Dr. Ahmed Ruzika. I want to ask you one question. What's the value of second look ultrasound after MRI? Do you want to tell us the second look to confirm MRI findings, or because any patient before doing MRI, he should do already, any female, mammosonography. So we don't accept to do MRI except after mammosonography. This means the patient already has ultrasound, then MRI. Do you think in the second look for you to confirm your diagnosis because it's missed from the first ultrasound, or what's the value?
Usually the second look ultrasound is requested after the sonography, the initial sonography and the MRI. This is requested because the MRI originally, the original sonography it missed the lesion or it didn't see the lesion. And it was only detected on MRI. Yes,
repeat ultrasound because
you need ultrasound to
missing
confirm
the
it.
lesion.
To confirm it's either pathological, something suspicious I should progress and take a biopsy from, or just a follow-up case.
Okay.
Yes, so to define a second look ultrasound, it means that you have done it beforehand an ultrasound, and then when you did the MRI, you found a lesion that was missed in the first ultrasound.
Yes, exactly.
So you had to do another and a second look ultrasound.
Exactly.
That's it.
Exactly.
Thank you.
Your aim is not under downgrading or upgrading.
No, because in MRI, say for example, like the case I presented, MRI said this is a suspicious lesion. If I would go and say, okay, this is a suspicious lesion, I should take a biopsy from it, you increase the number of biopsies because it's unnecessary. It turns out to be adenosis, turns out to be fibrocystic changes. And if you just depend on the MRI without the second look ultrasound, you're going to depend on taking it MRI guided, which MRI guided is obviously very, very costly, and it's not comfortable for the patient, not comfortable for the doctor. So with you detecting it on ultrasound, you either say it's actually suspicious, it should be biopsied, and at that time, at the same setting, you could take the biopsy. And at the same time, you either downgrade it completely and say this is nothing, this is not a suspicious lesion, this is for follow-up only.
Thank you.
دكتورة سلوى هي في point كمان ان يعني if we see a suspicious lesion on MRI that was not detected on sonomammography, we have to biopsy it. If we see a suspicious lesion on MRI and we didn't see it in the sonomammography, and it happens a lot actually. So when we do the second look ultrasound to target the biopsy, because we have no MRI guided biopsy. If we had MRI guided, we would have proceeded directly to a biopsy. بس. لا never. It's a second look after the original sonomammography. MR يعني comes as a second step after the initial.
حاجات ميزد من الالتراساوند.
بس يعني sometimes we started with the MRI. Sometimes يعني في البرايفت يعني مثلا.
بس it's not
يعني لا طبعا it's not يعني مش ده الرول مش it's not the role. In this case it is يعني very important ان احنا to do the ultrasound after the MRI. Of course.
Thanks, Dr. Rasha. Thank you, Dr. Ahmed Ruzee, for nice presentation. And now the next speaker, Assistant Professor Dr. Imam Fakhr, Women Imaging Unit, Al-Qasr Al-Aini, Breast Imaging Consultant, Bahia Cancer Center. Assistant Professor. The topic, or the title of the topic about film reading sessions.
Good afternoon, all. Thank you, dear professors and colleagues. I'm glad to be with you this year. And always I thank my professor, Dr. Rasha Kamel, for giving me this opportunity, as usual. I'm going to give a film reading session. Hope
ختامه مسك بقى يا إيمان.
نعم.
ختامه مسك.
يا رب. Hope you all wake up. And we will run rapidly through breast multimodality cases through the following 25 minutes. I'm intending to bring different cases, either typical, atypical, or dilemmatic cases, to cover as much as I can the pathologies, either benign, malignant, inflammatory, proliferative lesions, vascular lesions, and all are pathologically correlated, and all are Bahia cases. Okay, let's start. The first case is a 64-year-old lady with a palpable breast lump. We can see here her mammogram. She showed a right breast upper outer quadrant lesion. Enclosing the lesion, we can see that it shows a well-defined lobulated margin. But I think you can see here Okay, you can see here the irregular margin of the posterior aspect of the lesion, which led us upgrade the PIRAS of this lesion and asked for biopsy regarding the ultrasound also findings, which show the well-defined lesion with lobulated margin, but yet we can see here also the irregularity in this aspect, where it turned to be, after the biopsy, to be a fibroadenoma with DCIS. Okay, after that, there another case, a 35-year-old lady with left breast lumps. She had few masses. The largest one is a well-defined lesion, hypoechoic. We can see here internal cystic changes with microcalcification within, peripheral vascularity on color Doppler. Actually, it was a fibroadenoma also with DCIS. So what about this fibroadenoma with DCIS? In February 2019, Maronto et al. Found a pairing of common tumors like the DCIS within the fibroadenoma. They suggested findings that when we see in the fibroadenoma, we can upgrade the lesion, and we asked for biopsy. What are these findings? Mainly if they are increasing in size, if there is internal calcification, if the patient is old-aged, there's fine irregular margin, like the previous case, the internal cystic changes, if there is high vascularity or a high contrast enhancement. Okay, this is a 55-year-old lady coming for screening. Actually, you can see here a regional area of malignant microcalcification. I think this is a typical appearance of malignant microcalcification, as my colleagues referred. It's taking a linear distribution. Taking a linear distribution, reaching to the nipple. أنا كان نفسي أشاور عشان أوريكم بس. Reaching to the nipple, okay, and there is a cluster of microcalcifications in different coarse, heterogeneous, and pleomorphic microcalcification. This is a typical appearance of malignant actual microcalcification. This is another case for also a 50-year-old lady. We can see here. This is a focal area of microcalcification, which shows also a linear distribution with amorphous, mainly amorphous in shape, and this also a typical appearance of malignant microcalcification. This is a 50-year-old lady coming for screening. Actually, her first mammogram was completely normal. This was the following year. We found this area. I will zoom it up. You can see this picture. If I can assume of microcalcification, it actually was a weird picture. We investigated the patient. We asked the technician to go and ask the patient and to inspect the skin of the patient, asking for any skin application, cream, spray, powder. And actually, we found that the patient, it was after feast. So the patient was performing a tattoo, and it was a skin tattoo. So please put in consideration the topical applications of the skin, which can mimic microcalcification. Don't hurry and to upgrade the lesions to PIRAS 4 or 5 and ask for biopsy and took the patient to this dilemma before inspecting the patient, asking the patient, and asking the patient. I also have a similar case here. You can see here this case. This is a similar scenario. She was, a previous mammogram was completely normal, and this is the following year, and we found this calcification. Actually, we all said this is a suspicious calcification, and we will refer to the clinic, and it will take a biopsy, and blah, 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 the same dilemma. But actually, the right goes to Dr. Rasha Kamel. She, because this patient had an inverted nipple. She told me, go and ask the patient to revert her nipple, wash the nipple very well, and re-image the patient again. And actually what we did, and the patient just washed her breast, came again, we scanned the patient, nothing there. It just was only dirt on the inverted nipple. Okay, this is a 50-year-old lady coming with right bleeding per nipple. Here we can see an increase in increased tubular densities. And on the complementary ultrasound, we can see the typical appearance of dilated ducts with the internoductal echogenic increased echogenicity and the typical appearance of the pedicle vascularity, and it was just an intraductal papilloma. This is a 16-year-old lady. She had a left breast lump. On ultrasound, she is a 16-year, so she presented directly with an ultrasound. We performed her, found this large lesion, tubular in structure, increased the vascularity in color Doppler, taking a tubular distribution. Actually, on assigning the report, we suspected it may be an intraductal papillomatosis or papillomas, and we asked for biopsy. Really, the biopsy or the pathology came to be a fibroepithelial tumor, cellular fibroadenoma versus phylloids. This was the report. So here we come to a point, how can I differentiate fibroadenoma from phylloids radiologically? This is an important issue that we should take care of. There's a certain points we should know regarding the phylloids. It's more in older age. Recurrence is more common in phylloids. Size is larger in phylloids. The shape is irregular, more microlobulated. Calcification is more common in fibroadenoma than phylloids. And associated secondary findings are common in phylloids, mainly the malignant form, like the skin ulceration, the nipple retraction, the skin retraction, more than the fibroadenoma. And of course, the vascularity of the phylloids is more, showing a very hypervascular on-color Doppler. So what about the imaging? In the mammogram, both appears as a densities with the plus or minus smooth borders, either or. On the ultrasound, the fibroadenoma is a well-defined hypoechoic lesion. The phylloid shows microlobulated, ill-defined margin, and it may show internal cystic cliffs within. And on regarding the MRI, the fibroadenoma on T2 shows the hypointense internal septi, which is common to be seen in the T2, while the phylloids may confirm the internal cystic areas or cleft within. This is a 55-year-old lady coming with a left breast lump. We can all see here the abnormality. This is the lesion. To zoom it up, we can see this is a rather well-defined lesion of intermediate density. The ultrasound showed that the lesion is actually, yes, well-defined, but there is hypoechoic heterogeneous echogenicity with increased vascularity, actually, which led us to upgrade the PIRAS to be PIRAS 4A and take a biopsy. And this was done to turn to be an intraductal papilloma, again with focal DCIS. This is a 54-year-old lady coming for screening. We can all see this lesion. Actually, it's a nodule in the mammogram. It's well-defined. And the ultrasound shows also to be well-defined, oval-shaped, hypoechoic. Actually, it was assigned as PIRA 3, and we asked for follow-up. But unfortunately, her follow-up came to be increasing in size, which is confirmed by the ultrasound to not only the size, but here the margin again is not that nice. And we asked for biopsy, and it turned to be invasive duct carcinoma, which unfortunately was missed from the previous year. Okay, this is a 40-year-old lady with post-silicone implantation and coming with right breast lump. We can see here, this is an area of focal microcalcification taking more or less linear distribution. The patient performed the ultrasound. We can see in the right side this large lesion with abnormal vascularity, another adjacent small lesion as well. And the lymph node was infiltrated or pathological with non-uniform cortical thickening. She performed her MRI, as we know that the silicone, the examination of choice is the MRI to ensure if there is intra or extracapsular signs or to ensure any findings or abnormal findings in the breast. We can find here the lesion showing heterogeneous post-contrast enhancement with another smaller lesion, and it was suspicious. We took a biopsy, and it was post-silicone implant lymphoma, which was one of the complications of the implant, secondary complications, late complications of the implant insertion. Okay, we take a deep breath, and then we continue another entity. This is a 49-year-old lady with right indurated tender breast. This is her breast showing a global asymmetry with nipple retraction and abnormal lymph node, pathological lymph node. Her ultrasound shows an ill-defined area of abnormal shadowing which is increased vascularity on color Doppler, and she showed marked skin thickening with underlying interstitial edema. There is inflammatory signs, and yet her lymph node is not infiltrated. It's just showing uniform cortical thickening with central fatty hilum, but still it's suspicious. We performed her an MRI because it was like an indeterminate lesion. Okay, we found that, we confirmed the skin thickening in the T1, and the T2, we can see here the signal intensity is more or less intermediate bright. The lymph node here appears pathological. On performing the contrast, this is the dynamic and the subtraction image. We can see here the homogeneous post-contrast enhancement of the area. And on biopsy of this lesion, okay, this is the finding. It went to be a granulomatous mastitis. Okay, this is another lactating lady with left indurated tender breast. She performed an ultrasound with a abnormal echogenicity, abnormal shadowing, with a mild skin thickening, interstitial edema. Such lesion was increased vascularity also in color Doppler, and there was also a pathological axillary lymph node. We performed here an MRI. You can see here the edema, the interstitial edema in the T2 image. And also we can see here the parenchyma. We can see the foci of low signal intensity in the T2 weighted image, and also the pathological lymph node. The post-contrast enhancement, this is the dynamic, and this is the relative enhancement, or maximum relative enhancement, showed homogeneous post-contrast enhancement with the marked skin thickening, also biopsy, but this time it turned to be invasive duct carcinoma. So how I could differentiate, and both are completely different in prognosis and treatment. So it's very crucial to differentiate benign mastitis from malignant mastitis. This is the case, first case, and this is the second case. You can see that the both are very similar. We can see the area of abnormal shadowing with the overlying skin thickening. Okay, this one both performed the T2. This one performed her T2. We can see that it's a bright T2 signal intensity. So it went to be with benign mastitis. Yet the other case with low signal, the parenchyma showed low signal intensity in T2, so it went with a malignant mastitis. So to summarize, the bright T2 signal intensity with ill-defined collections, with mild skin thickening, all goes to benign mastitis, while dark T2 signal intensity, absence of collections, and extensive skin thickening with malignant mastitis. Okay, this is a 61-year-old lady with a right breast lump. We can see here this lesion, or we can see this is a few lesions. And this is also an area, more or less, more than being a mass, this is an area of architecture distortion. Okay, we performed her ultrasound. This was the right breast, showing multiple lesions, all shows ill-defined margins, high vascularity. Actually, we all will say that these are suspicious lesions. What about the contralateral side? It shows an area of altered parenchyma, which is highly vascular on color Doppler, and we performed her an MRI to ensure the extent and the characterization. Okay, we find that at the right breast, it showed there are multiple lesions of homogeneous post-contrast enhancement. While on the left side, we can see here an area of non-mass enhancement extending in the inner quadrant. So I have two different imaging features. The different imaging features suggest different logical diagnoses. The mass lesions went to be right invasive duct carcinoma, which are most common, and calcification also are more common in that cases. And the left went to be the lobular carcinoma, pathologically also, and it presents by asymmetrical architecture distortion rather than masses, and calcification are less common. This is a 52-year-old lady with right breast lump. We can see here more than one lesion, actually. We can see here this lesion, the large lesion of increased density. And there are another lesions here, 2 lesions. And we can see here an area of architecture distortion posteriorly to the large lesion. So you can see 2 lesions, actually 2 or 3 lesions, and this area of architecture distortion. What about the ultrasound? First, we found that this large lesion, it's a cystic lesion, complex cystic, maybe complicated, maybe, but this was a cystic lesion. Okay, this is another lesion, hypoechoic, oval-shaped with irregular margins. And this was another lesion, which is more to be echogenic and also ill-defined. So we have 3 different imaging features in the same breast and very adjacent to each other. It is so easily to report the patient as a multicentric lesion and away. But actually, we took biopsy, asked for biopsy from this 2 lesions, the 12 o'clock lesion, which is above the cystic lesion, and the area behind the lesion. This was an invasive duct carcinoma, and this was a sclerosed fibroadenoma. So actually we had 3, and the cyst, I think we aspirated also, and it turned to be a complicated cyst. So we have here 3 different imaging features in the same breast. So it's not easily to let the patient to be a multicentric carcinoma, such like that. This is a 59-year-old lady with right breast bulging lump. We can see this large lesion. Actually, it's a complex lesion. We can see here, this was a soft tissue shadow. At the same side, we find these lesions, and these are irregular, ill-defined, hypoechoic, suspicious lesions, actually. And there was another lesion, but this is oval, well-defined lesion. Again, two different imaging features, but both this time are suspicious. We asked for a biopsy from actually the 3 lesions. As we see here, we took 3 biopsies from the solid cystic lesion. We took from the solid component, from the solid component, from the cystic component. It goes to be intraductal papilloma and intraductal papillary carcinoma. This was a fat necrosis, and this one was a fibroadenoma. So we have also 3 different pathologies at the same breast. Okay, this is a 34-year-old lady with right axillary tail lump. This showed a cystic lesion, ill-defined lesion, okay? This was her ultrasound. We asked for biopsy from the suspicious, what we said, that suspicious lesion, okay? We performed her mammogram after the result of the biopsy. I will suspend the result of the biopsy. We performed the mammogram, and we can see the lesion here. There is a large axillary tail lesion of different lucencies and densities. Here we performed a second look ultrasound. We came the patient again, and we performed their second to confirm the lesion. Okay, this actually was the lesion. This was the whole lesion, not only the cystic space and the ill-defined lesion. No, this is the whole lesion. We took a biopsy from this lesion, and before we took a limited MRI study, T2 and STAIR, showing dilated cystic spaces. And on clinical review, the patient had like skin discoloration above this area with warts above this area as well since birth. On biopsy, it was lymphangioma. This is another lady, 57-year-old, right lumpectomy. We assigned it as a post-operative changes with coarse micro and macro calcific foci. She had also, this is the coarse microcalcification, and this dilated tubular structured axillary tail. There was this dilated channel and the skin thickening. We performed there also a limited MRI to confirm the findings we can see. We found this engorged, dilated vessel, which turned to be a vascular malformation. So this is an important entity, maybe not that common in the breast, but we should take care of is the vascular abnormalities of the breast, arterial and venous, and there are also benign and malignant vascular masses. There is maybe unilateral, bilateral, arterial, venous, or mixed. The common is the hemangioma, or we see the hemangioma, the AVM, the thrombophlebitis, and the benign malignant vascular neoplasm, hemangioma, lymphangioma, and angiosarcoma. I hope I could cover as much as I could in the etiologies of the breast, and thank you very much.
Thank you very much, Dr. Iman, for illustrative and very nice cases. And I observed that the contrast mammography here not used so much. And most of your diagnoses depend on the mammography and sonography, basically. And some cases, little for MRI.
I want to thank you, Iman, very much for the lovely presentation, your cases, and your and what I really want to support you for is the multiple biopsies you did for different lesions on the breast. It is very important when we see lesions on the breast, it's very easy to see the multicentricity of the lesion as a malignant lesion. But sometimes when you see them, they look different. You have to biopsy each and one. So thank you very much. I want to sum up before we go to the GE presentation. I want to make a wrap-up for this conference. I am really impressed, very impressed with the presenters, their English command, their slides, the very good slides of the mammography and the ultrasound. We used to always find agony in looking at the slides. But this conference really have changed my idea. It is really very interesting, very informative, and this shows that these presenters have a mentor behind them. So I want to thank very much Rasha Kamal for that.
I want to ask Dr. Iman, Iman, regarding the calcification within the within the fibroadenoma. Usually the calcification start as microcalcification within the fibroadenoma. So not every calcification in the in the fibroadenoma means that it is a complex fibroadenoma and require biopsy, because they start as a microcalcification and then coalesce and become the coarse or the popcorn calcification.
Because this we associate more than one finding, let us upgrade the lesion. Just microcalcification alone can't make me take a biopsy, and because for this we will biopsy all the fibroadenomas. We perform there 2 or 3 features, like it's increasing in size plus microcalcification. If there is a cystic lift plus microcalcification, old age patient, there might be 2 or 3 associated findings. We then ask for biopsy.
Our last presenter is Ms. Maria Smith. She's a women's health product marketing manager for emerging markets from GE. Her presentation is under the title Education Resources for Breast Radiologists, How GE Healthcare Supports Your Educational Journey. Ms. Maria.
Thank you so much. Can I pull it out? Thank you. I'm small, so I need to make sure that I'm in control of the microphone. Thank you so much, Prof. Rasha, and everybody, Prof. Hilal, of course. Thank you for your welcome. It's always so lovely to be here. I thought I would take it a more relaxed level, where we will, I'm going to introduce some educational resources that we provide, not only if you are a radiologist buying from GE, but of course if you're a radiologist and would like to have access to some online resources to do at your own pace. So I really enjoyed this topic, or this saying. They say there's nothing difficult. There are just some things that you have not yet mastered. And when I look across the room, I must be honest, I'm intimidated because there's a lot of brain power here. And, but I know that we're all on a journey. We're all on a journey of learning. And so what we'd like to just highlight is some of the things that we provide for you. So, of course, you may know that when you buy a piece of equipment from GE, we're going to do face-to-face training. That is a basic that is given. So we do the basic training, and then, of course, we do, depending on what you have purchased, we do the advanced applications, the biopsy. But I wanted to take it a little bit more, further, because you also may not know that you've got access to things like GE Cares, the Cenobright HD Club, which is a platform for CEM users, the Digital Academy, DetectedX. So that's available to GE customers. But then we've got other resources that are available to anyone as long as you've got online access. That's what I'm going to be doing. So what is GE Cares all about? Sorry, that went very quickly. I don't know what happened there. That was not supposed to go so fast. Sorry, can you start it again for me, please? To the fourth slide. Thank you. So GE Cares is a platform that will allow you to log in, and all you need to do is provide your serial number if you're a GE customer. So it doesn't have to be mammography. It can be any piece of equipment. It really is a community where you are able to learn and share and connect. And the beauty about this is that you've got access to things that have taken place in the past. Some trainings that have been done in the past, some webinars that have been taken place in the past, and you can really go and have a look at it in your own time. So you'll see some examples of, for example, USOBI that took 21. You're able to access that, some breast academies. So even our Prof. Rasha and Prof. Halal, who are speakers before in our breast academies of the past, you can go and listen to those lectures. And then we've got, things like CSM, guided biopsy. You can go and look and see what other people are doing with that. Some tips and tricks. So what is the considerations when you've got, when you're wanting to start up a CEM? DBT processing, how we do that. Some shortcuts on your keyboard for the workstations. So it really is a platform where you can go and learn and have a look and see how you can learn or access some tips and tricks. Then we've got something called the Cenobright Club. Now, what is this? This is a platform that has been set up by us, by GE, where you can, it is for CEM users. So basically, you will be connecting to this platform. It is a peer-to-peer forum, so you are able to go and post your own results, your own findings, your own ideas, and this is outside of GE's normal regulatory constraints. So it's not supposed to be something that we are telling you that is our opinion. It's your findings and your results, and you are connecting with other GE CM users. So you're able to post your results, you're able to get opinions from other users. And the beauty about this is that we don't edit or we don't control the content. So you really to do and to post whatever you wish. So that was the Cenobright Club. Then there's something called the Digital Academy. And I think you may find this interesting, whether you're a manager or whether you are part of a team. So when you purchase a piece of equipment, we give you some credits, and you're able to exchange the credits for this Digital Academy. And basically, you go on, you log on, you register as a student, and you're able to actually go through, we call it, you're going to be developing your own skills and in your. So there's a variety of clinical and product training across the modalities. And I think the beauty about this is that you do it at your own time again. You are, if you're a team leader, you're going to be able to follow up your team's progress and earning a certificate of completion at the end. And it really just adds value. If you are starting up as a young, in this case, radiographer or as a radiologist, you're able to see how you're gaining in competency, increasing your efficiency, and of course, ultimately, we're trying to help maximize the patient satisfaction. So the product structure would look like this. You'll go through a safety course just to make sure that you know how to operate the machine, all the basics of safety, a theory. So the course is an introduction to the product. It really goes through the main hardware features, how to use the interface. Then you get virtual hands-on. And I think this is where it gets interesting. It gives you practical examples of the workflow, the hands-on modules for basic acquisition or post-processing. And again, just to encourage the user, we're giving you a certificate of completion. So that was our Digital Academy. Over and above that, there's something called DetectedX, which I think, again, it might be really interesting. So we've worked with DetectedX, and we have put together a cohort of 2D and 3D cases, and you're able to literally log on from any laptop and go and review these cases. So they are 3D, and there's various different levels of difficulty. I think the beauty about this as well, getting immediate feedback, so you will know if you're finding those lesions or you're not. And it's using metrics, or several metrics like the sensitivity, specificity, true negatives, positives, and all that. I think, again, just in terms of gauging your capability, this gives you immediate feedback, which is really nice. So this is what it looks like. You can log on and access it, and you can go through the cases at your own leisure. It gives you the comment of or a little bit of history about the patient, and then the ability to detect where you think the cancers are, what are the BI-RAD categories. You're able to select that, and then find the lesions. And then it gives you feedback. The comment, yes, you're right or wrong, or go back, and this is where the lesions were. So I think it's really, again, for young radiologists learning how to tackle these sometimes clinical cases. It just gives you your own time to practice and to be comfortable with no one watching you, but ultimately you do get the feedback. Then some of the platforms that we have that are accessible to all, and Prof. Kamal, I think you may find this interesting for startup radiologists. It's called the Cinebright HD e-learning. Again, accessible to all, no cost. You just need to, I'll give you the link, anybody can access it. And the beauty about this is that we've worked with key or well-known radiologists across the world, so you may recognize some of the names. And I think the thing about this, it's not an academic course, but it really is how these particular radiologists have implemented CEM and how, you know, what the experience has been, what they've found useful to have. So as an example, I just put in some things that would be covered in a module, so clinical training. And this is dedicated to understanding the clinical value of CEM through case reviews. You will take approximately 2.5 to 3 hours to cover this. So it's really not just a very superficial course that you take. It really goes quite in depth, and by the end of the module, you'll understand from the speakers the clinical situations in which CEM is helping, how to know the potential limitations, you're familiar with the artifacts, and you even go through reporting or have the ability to report on the CEM cases, and so on. So again, this is something very nice for somebody who's perhaps thinking of implementing contrast-enhanced mammography. And like I said, it's accessible to anyone. You just need to ask me for the link, and I'm happy to share it, because I think there's some value in this. Just as an example, what you see, so you'll see in this case, Dr. Globes going through some cases, and you'll see here the welcome, and then you go through the clinical training, how to set up the process, the contrast management, you go a little bit deeper. So yeah, we just thought I would let you create awareness that this is available to you all. We've also got a very clever lady who's Karima Santi, and some of you may know her, and what she did was she recorded about 1.5 hours of DBT cases with different, from different sites around the world again, cases with different abnormalities, and what she does is she goes through each case, different levels of difficulty, and it really just, you can pause, stop, it shows you our workstation, the tips and tricks and how to manage that. So again, this is available to anyone who thinks they might, you know, want to use it. I think it's just always interesting to see different cases from around the world, and again, it's an asset that you're welcome to have and to review. And finally, I think there's such a big focus on AI, and I recently discovered that GE contributed to the content in this program called Hello AI. What is it? It's a program, it's online again, self-paced. Unfortunately, this one is not for free. There is a cost to it, but there's such a lot of emphasis on AI, and this is really something that perhaps would be interesting for somebody who's interested in going through a little bit deeper about understanding AI in healthcare. And you can see there's a basic course with 52 lessons, there's a more advanced course for 121 lessons, and then for professionals. So this is really just to create awareness. GE was part of developing the course with European healthcare workers. So again, the basics is just for anyone interested in AI. Then we've got the advanced course for students and researchers, and you're getting credits as well. So this may be something interesting to use in your development or your knowledge of AI. The program is blended on learning experience, and I think the beauty about this is that it varies in complexity. So from something very basic, what is AI, the deep learning tools that they use, but then you go through to a more complex deep dive of artificial intelligence specific to healthcare and its benefits for medical professionals, and then ultimately for patients. Yeah, and if you need more information, again, I'm very happy to support that as well. But it really was just an overview of, often we trying to sell you something. This time we're not selling you anything, we're just making you aware that we value education, we value all that you do, and sometimes it's just nice to know there's other resources from international platforms, international speakers, international radiologists, and it's accessible to you with our deepest pleasure. So thank you. I'm not taking up all my time. I'm going to give you some time to go and have some tea. And thank you for the invitation. And honestly, the partnership means a lot to us as GE. Thank you very much.
Thank you very much, Ms. Maria, for this very nice lecture. And thank you for GE supporting education. Any questions for the few that are waiting for the last session? Any question to Ms. Maria? Thank you very much. Okay, we come to our closing session. Thank you very much for your attendance. Again, once more, I want to thank Professor Rasha Kamel and the presenters for the